We're in the middle of October.
Right, so that pharmacist is supposed to get a meeting Monday.
Okay, yeah, I mean, it's just, yeah, there's.
It's a little early for the
Well, we usually,
Shots.
we start pushing it out in October this time.
Okay.
You can actually get it starting in September if you have a provider that's offering it.
Test 1, 2, 3.
Purchases
Test.
doses for us, they can get them. So
Okay,
that's why
right.
we don't have them as a health department.
Ah.
But most-
Testing 1, 2, 3. Test audio. YouTube mic check 1, 2, 3.
Okay, well, make sure you get it, because we were just looking at data on flu, that's a little too vague even.
I'm interested in the dirty water. That's what I'm interested in.
Okay, we're gonna talk about it.
Everybody else is.
Test 1, 2, 3. Test 1, 2, 3.
Yeah, it's plateaued. I
Yeah.
mean, we don't have a decline here, that's for sure.
Okay.
But, yeah.
Test microphone 1, 2, 3. Test 1, 2, 3.
You came back?
I'm here, hi. Ellen said to say hello back.
Okay, good,
Yeah,
good,
I
good.
mentioned it for sure.
Oh, thanks,
Yeah,
thanks.
of course. Hi there. Hi. Haven't seen you in so long.
Test microphone 1, 2, 3. 1, 2, 3. Test microphone 1, 2, 3. I think we have 1 minute. I'm just trying to get the sound right on YouTube. Test 1, 2, 3. Okay. I think we're good. There's one back there.
Hello. Good afternoon, everyone. Thanks so much for joining me for today's briefing. I'll give a COVID-19 status update for LA County. My presentation will be followed by an update on monkeypox from Dr. Singhal, the Chief Medical Director for the LA County Department of Public Health. In today's presentation, I'm going to share current COVID metrics. We'll look, as always, at the LA County alert signals, some new information on long-term risks that are associated with COVID, and then we'll review how the bivalent COVID booster works and who's eligible. I'll go to the first slide. Each week, we do look at this updated trend line. It shows cases, hospital admissions, and deaths. In this figure, that green trend line is the 7-day average of number of cases that are reported daily. It's measured using the vertical axis on the left. As you can see, for the past week, we had an average of about 1,185 cases reported per day. This is, again, an 8% decrease, and you can see that the line is going back down, the green line, from last week where we reported almost 1,300 cases a day. The 7-day average for the number of daily hospital admissions is on the orange line. It's measured using the vertical axis on the right. This metric has plateaued with an average of around 78 admissions per day this past week. That's a slight increase, and again, you can see that on the trend line from the average of 76 admissions per day we saw last week. The blue line on this slide shows the 7-day average number of deaths reported daily. It's also measured using the axis on the right. We did see a slight decline in this metric. We moved down to an average of 10 deaths reported per day this week compared to 13 a couple of weeks ago. A significant proportion of our deaths continue to be among older adults and those with underlying health conditions. Although sadly this week we are reporting our 14th pediatric COVID-associated death. We do know that every death is felt deeply by families and their communities, and we send our condolences to all who are mourning a loss. Next slide. We continue to use the CDC's COVID-19 community levels framework to monitor the strain on our healthcare system. For the 6th straight week, CDC designated LA County at the low COVID-19 community level. That first metric that we use is the weekly case rate. As a reminder, since the state switched to reporting case counts to CDC only once a week, we are using our locally reported data to calculate the case rate. Today, our weekly case rate is 81 cases per 100,000 people. That's a decrease from 88 that we reported last week. The first of the two hospital metrics is the weekly total of new hospital admissions per 100,000 people. It's currently reported at 5.1 weekly hospital admissions per 100,000 people. It's very similar to where we were last week. I think it was 4.9. The second hospital metric is the 7-day average for the proportion of staffed inpatient beds occupied by COVID-19 patients, and this is the same as it was last week at 2.9%. Next slide. This past week, there were small increases in two of the early alert signals we monitor, and they bear watching over the next few weeks. The first is there was an increase in the percent of BA.4.6 specimens that were sequenced. We moved from 3% of our specimens being BA.4.6 to 5%, and I'll talk a little more about the variants on the next slide. And I also want to note that the number of new outbreaks in TK through grade 12 school classrooms increased from 11 to 17. This is still a relatively small number, but again, something we'll be watching carefully. As we've noted in the past few weeks, most of our early alert signals, and you can see that here with the dark green color, are of low concern, with the weekly case rate in the lowest income areas decreasing slightly from 62 to 57 new cases. Reports of the number of new worksite clusters also decreased from 68 to 54. There was no change in the number of new outbreaks reported this week for people experiencing homelessness. It remains at 2. And the percent of emergency department encounters classified as COVID-related held steady at 4%. Although the wastewater metric is still pending this week, I will share the wastewater concentration levels for each system in a minute. Next slide. This is the variant slide. The Omicron variant, which started to dominate all the way back last winter, continues to account for 100% of the sequenced specimens. The BA.5 subvariant of Omicron, that's the large bright red sections on each bar, remains the predominant subvariant in LA County, making up nearly 90% of our cases. CDC estimates that for the week that ended October 1st, 90% of the specimens in Region 9, which is California, Arizona, Nevada, Hawaii, and the U.S. territories in the Pacific Ocean were BA.5, very similar to us. Across the country, CDC estimates that 81% of specimens were BA.5, reflecting the increase in other parts of the country in some of the subvariants and sublineages. This past week, though, we did have some small increases in a few of the sublineages that we're monitoring. As you can see, BA.4.6, that's the yellow bar on these graphs, increased from about 3% to 5% this week. BA.2.75 now accounts for 1% of the specimens, with about 42 specimens to date. That's an increase. Last week we were at 30 specimens. We also have 3 LA County specimens that are BA.2.75.2, which we're going to watch closely. It's a super small number, but this is a sublineage that's been spreading in parts of Asia and Europe. And it may both evade prior protections and not respond currently to some of our currently available treatments. 2 weeks ago, we began tracking a new subvariant called BF.7. It's a sublineage of BA.5. Sometimes it can be called BA.5.2.1.7. So far, 50 sequenced specimens in LA County have been determined to be BF.7. So that's now about 1.4% of the sequenced samples. While we're noting the small increase in 3 of the sublineages that are being tracked because of their immune-evading properties, the new sublineages currently circulating are increasing very slowly, as you can see on the graph, and they're not yet crowding out BA.5. While this is no assurance that in the weeks ahead there will not be an acceleration in the proliferation of these strains, because they appear to have mutations that can help them spread easily, there is hope that with increased uptake in the fall boosters, which are well matched to what's circulating now, and the use of common sense precautions as we move into cooler weather months, we can blunt the impact of the anticipated increases in transmission that may be associated with these new strains. Next slide. We also continue to report our wastewater concentrations of SARS-CoV-2 and we triangulate this data with case data to assess trends in community transmission. This slide shows wastewater treatment trend lines across the 4 plants in LA County. And as you can see, looking at the recent data, viral concentrations in wastewater remain constant without any substantial declines. This plateau in the viral concentrations in wastewater is likely to signify that viral transmission in LA County is no longer decreasing. The most recent observations of viral concentrations at these 4 wastewater plants, along with the small increases we reported in a couple of the early alert metrics, highlight the need to carefully monitor the early alert signals to see if in the weeks ahead we have any additional signs that suggest changes in our transmission patterns or illness severity. Next slide. Schools are required to report when they have 3 or more linked cases in 14 days, and our department will follow up on all of the reports and determine whether or not there's been viral transmission on site or at a school activity. If we find that viral transmission has occurred, then we consider that an outbreak, and that's what we're tracking here. This slide shows the number of new outbreaks in TK through grade 12 school settings and youth programs, started in the summer all the way through to the week that ended October 1st. Since school districts opened in August, we've had a total of 68 outbreaks in elementary schools, that's the light purple, 19 outbreaks in youth sports programs, that's the orange color, and these continue right now to be primarily football and volleyball. 27 outbreaks documented in middle schools, as you can see with the light blue, and 15 outbreaks in high schools, that's the dark blue. You can see that the number of newly confirmed outbreaks peaked the week that ended August 27th, declined for 3 straight weeks, but then started increasing again. There were 20 new outbreaks in the most recent week that ended October 1st. This increase was driven primarily by increasing numbers of outbreaks in our elementary schools. As we get into the fall and closer to winter, when we expect transmission to be higher, we recommend that schools take sensible prevention measures to avoid disruptions. This includes particularly encouraging eligible students and staff to get the updated COVID-19 booster, optimizing ventilation to the extent possible, masking and testing after an exposure, and encouraging students, teachers, and staff to stay home when they're feeling sick. We do thank our many partners at schools who are doing a great deal of essential work to keep students and staff safe. We also thank the many, many parents who keep their children home when they are sick and get them tested for COVID. We recognize the challenges in keeping children home when ill, and we appreciate all the efforts to reduce transmission. Next slide. In general, older adults are more likely to face the higher risk of severe symptoms or death from COVID than young adults or children. However, for children infected with COVID who develop multisystem inflammatory syndrome in children, sometimes called MIS-C, the impact can be severe. MIS-C is a condition where different body parts can become inflamed, including the heart, the lungs, kidney, brain, skin, eyes, or gastrointestinal organs. This generally occurs 2 to 6 weeks after a typically mild or asymptomatic COVID infection. So far in LA County, we've seen a total of 319 MIS-C cases. The majority of these cases, 82%, have been among children between the ages of 1 and 14, with the largest proportion, 30%, in small children ages 1 to 4. MIS-C cases remind us that we're still learning about the long-term health effects of COVID infections. And even among children, where the risk of becoming ill is relatively low, COVID infections can have long-term consequences that end up being dangerous for some. Next slide. This year, there's been mounting evidence that long COVID is also a significant problem for many adults who have been infected with COVID-19. While there's no standardized definition of long COVID, in general, long COVID usually refers to symptoms that continue for a month or longer after initial illness. The most described symptoms of long COVID include fatigue, reduced exercise capacity, breathing problems, brain fog, and loss of taste or smell. In some cases, people also report sudden hair loss that lasts for months. It's still not clear how frequently long COVID occurs, but it isn't rare. Estimates vary considerably from about 5% to close to 40%, depending on the population studied. Those who've been hospitalized for COVID tend to have a higher risk. In a newly published study that followed healthcare workers in Italy for 2 years, between March 2020 and March 2022, 31% of healthcare workers who had been infected with COVID and were not hospitalized reported having long COVID symptoms that lasted for more than 4 weeks. There were also a pair of studies this year that found an increased risk of developing long-term health disorders among veterans that had COVID. In the first study, researchers found that at 6 months after infection, those who had been infected more than once had a 2 times higher risk of death, 3 times higher risk of needing hospital care, and 2.5 times higher risk of developing heart or lung disease, or problems with blood vessels and blood clotting, when compared to those who had been infected just once. The risk of having long-term health conditions was 3 times higher for those infected 3 times compared to those who were uninfected. In their newly published study, researchers found that at 12 months, those who had had COVID had a 42% higher risk of neurologic disorders than those who had not had COVID. Many of these disorders were serious and life-changing and included stroke, cognition and memory disorders, peripheral nervous system disorders, migraines, seizures, movement disorders, mental health disorders, disorders of the musculoskeletal disorders, and among other disorders that were listed in the article. Remember, this was studies on tens of thousands of veterans across the country. These studies are a sobering reminder that even when symptoms are not severe enough to require hospitalization, COVID can be disruptive for many. While we continue to better understand the impact of COVID on our long-term health, it is prudent to take sensible steps to avoid infections, and particularly reinfections. Next slide. As we think about what steps to take to reduce the risk of long COVID, many have wondered whether the original vaccines, which we have used before the bivalent booster and which are very effective at reducing severe illness and death from infection, are also reducing the risk of developing long COVID. A couple of recent studies provide evidence that vaccinations are indeed protective against long COVID. The first study systematically reviewed other studies published on long COVID and vaccination through June of 2022. The authors identified 6 quality studies that provided insight on whether vaccination before SARS-CoV-2 infection reduced the risk of developing long COVID afterward. All 6 studies found that vaccination lowered the risk. The second study on whether vaccination can reduce the risk of long COVID is the same paper we discussed a moment ago, a study that followed more than 2,500 healthcare workers in Italy for 2 years. They found that compared to those who were unvaccinated, being vaccinated before getting COVID reduced the chances of developing long COVID. Those who had 2 doses of vaccine before getting COVID had an approximately 75% lower chance of getting long COVID, while those who had 3 doses had an 84% lower chance of getting long COVID. While there remains much to learn about long COVID, with increasing evidence on the protective factors associated with vaccinations, getting vaccinated and boosted appears to be one of the simplest steps to take to reduce the chances of developing long COVID after an infection. Next slide. Ever since vaccines have become widely available, we've been analyzing local data to compare COVID outcomes in vaccinated and unvaccinated individuals. This has been especially important this year with the proliferation of new, more infectious subvariants of the Omicron variant. On this table, we compare recent rates of cases, hospitalizations, and deaths in unvaccinated versus fully vaccinated residents, using data that started spanning from mid-August to about mid-September of this year. This was before the new bivalent booster became widely available, so the data isn't including individuals who received the new fall booster. In this analysis today, we use the term fully vaccinated to include only those who completed their initial vaccination series. Those who were fully vaccinated and received at least 1 booster dose are shown separately. For the 30-day period that ended September 14th of this year, unvaccinated residents were almost 3 times more likely to get infected than fully vaccinated individuals, and 2 times more likely to get infected than those who had been boosted. While puzzling to note that those with at least 1 booster dose were slightly more likely to get infected than those who had received only the initial series, this likely reflects the fact that as more infectious variants have emerged that are capable of evading prior immunity, the current vaccines, not including the bivalent booster, have become less effective at reducing the risk of transmission. The power of the vaccines, even against the highly infectious Omicron variant, is undisputed in preventing hospitalizations and deaths. And here the boosters did make a difference. During the same 30-day period, unvaccinated LA County residents were 3.5 times more likely to be hospitalized with COVID-19 than fully vaccinated residents, and almost 4.5 times more likely to be hospitalized than boosted residents. Finally, over the same 30-day period, unvaccinated residents in LA County were just over 4 times more likely to die from COVID than vaccinated residents, and more than 6.5 times more likely to die from COVID than boosted residents. Next slide. For those of us already fully vaccinated and boosted with 1 dose, it can be confusing, with 1 or more doses, it can be confusing to hear that we need another booster, especially since, as I just showed, although the original vaccines provide less protection against transmission of the virus, they continue to provide significant protection against severe illness and deaths. One reason for getting another booster this fall is because the immunity we get from our vaccines and/or from getting infected wanes over time. And we have seen clearly with the data where over time the differences between case, hospital, and death rates between vaccinated and unvaccinated individuals has grown smaller, that in fact there is this waning protection. Another reason for getting boosted now is because the virus has mutated significantly over the past 2.5 years, and the new strains may evade some of the vaccine protections or the protections from previous infections. But let me focus for a second on the bivalent booster, which is newly formulated to protect from the current variants that are circulating. Both the Pfizer and the Moderna bivalent boosters are mRNA vaccines, and therefore they work in the same way. They're also both bivalent vaccines, meaning they provide protection against 2 variants of the virus. This has been an approach that's been used with other vaccines as well. For example, that seasonal flu vaccine that we all get every year is a quadrivalent vaccine, meaning it provides protection against 4 strains of the flu at the same time. All mRNA vaccines contain RNA that codes for just a fragment of the virus, and in this case, the outer spike protein. Bivalent boosters contain mRNA that codes for 2 different spike proteins, one from the original virus, we call it the ancestral strain, and one from the Omicron BA.4/BA.5 subvariants. And you may be wondering why we keep saying BA.4 and BA.5 together, because these viruses actually have differences from each other, but they have the same spike protein, and the new bivalent booster provides protection against that spike protein. When you get the bivalent booster, your body uses the mRNA in the vaccine to make copies of non-infectious viral spike proteins. To your immune system, these spike proteins look the same as the spike proteins from the real virus, even though there's no live, complete virus that's present. Your immune cells capture these copies of spike proteins and then create antibodies and stimulate immune cells that can recognize and fight the actual virus if you get infected later with either the original virus or a subvariant of Omicron BA.4 or BA.5. While the primary series 80% of us received earlier in this pandemic still provides decent protection against severe illness and death, getting a bivalent booster helps you retain and update the protection you already have. And this is very important as we move into the cooler months when we spend more time indoors and more time gathering for celebrations and holidays. Because the bivalent booster has great potential for providing significantly increased protection against Omicron, which is what's circulating now, This boost to the immune system has the potential to make a big difference in reducing disruptions and heartache this fall. Next slide. Hopefully, understanding how this vaccine works clarifies the advantages of getting the new booster. And the good news is that millions of residents are eligible. Anyone who's 12 or older and who received at least the primary vaccine series is eligible as long as it's been at least 2 months or more since their last COVID vaccine. If you already received a booster or even 2 boosters before now, you can go ahead and get the new updated bivalent booster, and you're encouraged to do so as long as it's been at least 2 months since your last vaccine. Children ages 12 to 17 can only get the Pfizer bivalent booster, while everyone ages 18 and older can get either the Pfizer bivalent booster or the Moderna bivalent booster. As a quick note, the FDA is reportedly planning to assess the Pfizer bivalent booster for children ages 5 to 11 next week, and if authorized, it's likely to be available here in LA County as soon as October 19th. Next slide. There are 7 million people in LA County who are eligible for the bivalent COVID boosters, as you can see on this table. To date, just over 355,000 have been boosted. This leaves over 6.5 million of us that need to still take advantage of this important layer of protection. While older residents are more likely to have received the bivalent booster than those who are younger, the numbers are still very low. Only 10% of residents ages 65 and older have received the new booster, with almost all residents in this age group eligible. Given that people over 65 face the greatest risk of severe disease if they get infected, these low numbers are a cause for concern. Next slide. While we do know that there are some residents who may be waiting to get this fall booster because they were recently infected, we fear that there are many others who are confused about the new fall bivalent booster, have unanswered questions, or are struggling to get to a vaccination site. Because those who are older face the greatest risk of severe disease or death, a top priority is to make sure that older residents have easy access to information and the new fall boosters. We need your help. If you're an older person or someone who has older people in your life, at work, at home, or in your community, please let them know about the importance of getting this additional protection and ask them if they have questions or need any help getting their new fall booster. We continue to offer in-home vaccinations and transportation services for all homebound residents to help ensure that they have good access to COVID vaccines. We ask that you call the LA County Public Health Call Center at 833-540-0473 for more information about the fall boosters, or to request an in-home vaccination appointment, or for help with transportation to the nearest vaccination site. The call center is open every single day between 8 a.m. and 8:30 p.m. In closing, I thank everyone in advance for coming together to help those at highest risk for bad outcomes from COVID. I worry a lot about the potential for our death rate from COVID to rise again this winter, disproportionately affecting those who are older. However tired we may be of dealing with this shape-changing, mutating virus, I hope we can rally as a community and make every effort to protect our most vulnerable residents. This new fall bivalent booster can save lives. And now Dr. Singhal, the Chief Medical Director for the LA County Department of Public Health, will give an update on monkeypox, and after her update, as always, we're happy to answer your questions. Thank you. Grab your stuff. Yeah, I'm gonna get this. Okay. Thank you.
Okay. Thank you, Dr. Frere. Good afternoon. Thank you for being here. Today I'll be presenting a situational update, new case rate data for LA County, including trend data by race ethnicity, an update on our vaccination efforts, and reminders for our residents on what to do if they've been exposed to or may have monkeypox. I'll take the first slide, please. I'll lead off with our routine situational update. Over 70,000 monkeypox cases have been reported globally, with over 26,000 of those cases reported in the United States, including 5,010 cases in California. As of today, there are 2,072 cases in LA County, as well as 114 cases reported in Long Beach and 27 cases reported in Pasadena. On September 30th, the Ohio Department of Health reported the death of a person due to monkeypox. This is the second confirmed death for monkeypox in the United States. Across the world, there have been 14 confirmed deaths in non-endemic countries, including the 2 in the United States. This latest death is an important reminder that although most people with monkeypox have had mild to moderate illness, it can lead to severe illness for some people. Given this risk, immunocompromised persons with monkeypox should seek medical care and treatment early and remain under the care of a provider throughout the course of the disease. Healthcare providers should report and consult with the public health department on any hospitalized patients, especially those with worsening disease. Next slide, please. Next, I'll review our latest monkeypox case trend data, which is shown here on our epidemiological or EPI curve for monkeypox cases by episode date. Daily case numbers are shown by the blue bars, and the 7-day average cases are shown by the dark pink trend line. As of September 24th, our 7-day average cases had dropped to 9 cases, which is the lowest that we have seen since early July. As you can see, the downward trend in our 7-day case average that started the 3rd week of August has continued. We remain encouraged that we continue to see this steady decline in cases in LA County. CDC reported in their latest technical report that the slowing growth of the monkeypox outbreak in the United States is most likely due to a number of factors that include vaccination, behavior change, and possibly infection-acquired immunity within networks where high transmission of monkeypox was occurring. They are also hopeful that the declines in new cases will continue in the coming weeks. Next slide, please. To continue to highlight the disparities in who monkeypox is affecting, here are case rates by race, ethnicity, and episode date. The colored lines indicate the 14-day cumulative rate over time, adjusted for age. The green line represents the rate for Black or African American residents, the blue line for white residents, and the red for Latino residents. Other race categories are not shown due to unstable data from small case numbers or low case rates. You can see here how the communities that have been most impacted by monkeypox have evolved over the course of the outbreak. Cases first appeared, peaked, and started to decline in white residents. We see a similar curve and case rates for Latinx residents, although with a later start, peak, and decline. On the other hand, the case rate for African American or Black residents has been substantially higher than for white or Latinx residents for most of the course of the outbreak. For instance, at its peak, the case rate for African American residents was nearly twice as high as the peak case rate for white residents. The good news is that although a gap still exists, case rates for Black or African American residents peaked at the same time as for Latinx residents and have been declining at about the same pace as other groups. Public health continues to work with community partners to address these disparities by increasing awareness about monkeypox, implementing strategies to increase vaccination rates in underserved communities, and improving our communication and outreach efforts. Next slide, please. Vaccination remains a key strategy in our monkeypox control efforts. We've received a total of 73,864 vials of Jynneos, which equates to about 196,000 total doses of the vaccine. As of yesterday, 53,126 vials, or 98,856 doses of the Jynneos vaccine have been administered. This means we've administered about 50% of the doses that we have received. 1 dose of Jynneos vaccine is very effective in protecting against monkeypox infection, but because the durability of protection is unknown, it's important to complete the 2-dose series to receive maximum benefit. Our latest vaccination data indicate that about 70,670 persons have been vaccinated with at least 1 dose, and 27,657 individuals have completed the 2-dose series of the Jynneos vaccine. Although our increase in number of doses administered has slowed over the past several weeks, especially at our public vaccination sites, our community providers are holding steady on their weekly doses administered, and we are hopeful that they will continue to successfully identify and vaccinate eligible residents. Next slide, please. I'd also like to share some reminders for what residents should do if they think they've been exposed to monkeypox or think they may already have it. If you think you have monkeypox or suspect you've been exposed, visit a healthcare provider and tell them about your exposure and any symptoms you're experiencing. If you have been exposed but do not have symptoms, you should get vaccinated as soon as possible. This can prevent you from becoming infected with the monkeypox virus. If you've been exposed, it is best to get vaccinated within 4 days of exposure. If you do develop symptoms, the monkeypox vaccine is no longer indicated, should get tested and evaluated for TPOXX treatment. If you are immunocompromised, including living with HIV, it's especially important to seek medical care if you have symptoms that are consistent with monkeypox. In addition, if you are exposed to monkeypox through sexual contact, get tested for HIV and other sexually transmitted infections as soon as you are able. If you are diagnosed with monkeypox, it's important to follow the Department of Public Health's isolation instructions for people with monkeypox, which can be found on our webpage under monkeypox resources. Instructions include staying at home, keeping the rash covered, and not having any close contact, including sharing items with others and pets. You can also ask your medical provider if they recommend TPOXX, an antiviral drug currently recommended for people with severe monkeypox disease or those who are at high risk of severe disease. Next slide, please. In closing, for more information regarding monkeypox prevention, management, and treatment options, please visit our website at ph.lacounty.gov/monkeypox. You can also visit the site for the latest resources, including vaccine eligibility criteria, information on minor consent, and links to vaccination sites throughout the county. The Public Health Call Center is available to any resident who doesn't have access to the internet and needs information. Thank you.
Go ahead and facilitate questions.
I have one for Dr. Ferrer. What was the age of the minor who died of COVID?
Yeah, we don't give out any information. It's just,
You want to say if it's missing?
oh, if it's MISC, yeah, usually we do say if the death is associated with MISC, and I think we've calculated the number of deaths associated with MISC. I want to say that number's 4, but don't quote me. We'll get you the right number on that, but this was not an MISC.
This is not it.
Yeah.
MISC, okay.
We do give that information, but we don't give information on the child's age.
And another question. How concerned are you about the increase of B4.6 from 3 to 5%?
I don't think concerned would be the word I would use right now, because in general, I feel like our trends are favorable at the moment. We've seen, that's why we show that graph. You could see how slowly we're seeing that increase. I worry a little that when conditions are more favorable for transmission, we're all indoors a lot more, we're gathering with lots of people, there's a lot more travel. A variant that has an advantage on transmission, evades protections more easily, will flourish. And I look very carefully at what we're seeing across the country and in Europe, where they're already experiencing that colder weather, which drives people indoors more earlier than we go indoors. And I'm seeing that they have more of BA.4.6 circulating. So I think we need to be prepared for increases that are likely going to be associated with the colder weather and moving indoors, as well as with the proliferation of some, sublineages that are going to have some advantages.
Does it worry you that only 5% of eligible residents have gotten the bivalent booster?
Yes, so that is my concern. I'm not so concerned about, the fact that we're having sort of slow increases in what we're seeing in terms of the proliferation of new subvariants. I just know that we've finally, in front of us right now, have this opportunity to have a vaccine that exactly matches what's circulating. And I'm hoping that over time we can clear up any confusions about why it's important for people to go ahead and get another booster dose so that those numbers go up. Those numbers actually need to increase pretty dramatically before we get into the holiday season, or we run the risk of having more transmission than we need to have.
Is it frustrating?
Well, I don't think the word is frustrating. I think it's complicated, and I think, we've been in this space before where it's a complex set of circumstances that we all find ourselves in. I understand the sort of fatigue of like, you got to be kidding me. I'm vaccinated and I've gotten 2 boosters, and you're telling me now I got to come in for the 3rd? And you're also showing me data that says these vaccines still work pretty well on protecting us from the worst outcomes from COVID. I think the difference is pretty well versus, really being powerful, especially for people at higher risk. So my real concern is with older people, people with underlying health conditions. This will make a difference in their lives, and we do need them to understand how important it is to think about coming in annually or even more frequently to take advantage of the updated protections that you get. In many ways, it's like flu vaccine, and many elderly people are used to coming in and getting that annual flu vaccine because what's circulating, you're trying to match what's circulating. This case, we've got a very good match. And so my hope is that as we are out in the community more, we're talking to people more, and people are talking to each other because we know this spreads through social networks, this information. More people will get comfortable with coming in and getting that booster dose.
Are you bivalent boosted? And in terms of symptoms, can people expect the same symptoms that they may have felt from the booster?
Yeah, it's a great question about, sort of what are the symptoms, and most people report the same exact symptoms. We've heard from very few people that feel like they've gotten sicker on this go-round than they have in the past. Most people say they actually had less side effects to the vaccine on this go-round than they had in the past. But everybody's different. Everyone should be prepared for some minor inconvenience associated with getting vaccinated, as with all vaccines.
And have you been boosted by the bivalent?
I'm struggling because I think, my sort of personal story is complicated on the vaccines, and I'm not really sure it's relevant. This is what I can say, is when I am cleared to get that booster, I will go ahead and get that booster because I think it's super important. And that for me will happen soon. But I think like many other people, I coordinate with my clinical team about the timing on getting vaccinated.
Okay.
Do you have anything else?
I do.
Go for it.
What do you say to people who see you here today with a mask, with very few people here who we are masked, and see a photo of you circulating in a stadium at a concert setting, a stadium that holds tens of thousands of people without a mask, and are confused by the mixed messaging? And bottom line, what is the message around masking of when to mask versus when not to mask?
Yeah, thanks for the opportunity to clarify. I'm indoors whenever I'm indoors with other people that I don't know well. I always have my mask on. We also all keep our masks on at work still because it would be super hard on us if we had an outbreak on this floor because of COVID. I mean, we're all working still pretty hard. So I'm very careful indoors. When I'm outdoors, I'm less careful. Those people who have seen me at events know that in any of the indoor areas, the walkways coming in, my mask is always on. My mask only comes off when I'm outdoors, and it may be crowded, but I'm not crowded. If I'm in a crowded situation, I try to make sure that mask is on. Sometimes I'm eating or drinking like other people at those events. But in general, I believe strongly that the place to keep your mask on is indoors when you're around lots of other people.
And SoFi isn't considered?
No, SoFi is considered an outdoor venue because they have a lot of, they have opening. They do have that sort of high roof structure, but the sides are all open. So they've been designated an outdoor venue. I think you'll notice that for that particular concert, once the concert started, my mask was on the entire time because there were a lot of people shouting and having fun, singing, and my mask stayed on at that point.
And you're still healthy.
And I'm still healthy.
What do you say to people who are surprised you're a Bad Bunny fan?
I love Bad Bunny. I'm Puerto Rican, Boricua en la casa. So yes, I love Bad Bunny, and it was a great show. And I'm glad, like everybody else is, that we can get back to enjoying the things we really love.
Okay. I do have another question.
Go for it. Then we'll go to Ron after
Okay.
the next one.
I know you're not surprised. Close contact mask mandate. It's a question I've asked before, so I just want to revisit it because there isn't a clear-cut answer, so I'm curious if you do have that now, and that is, what is your target, what is the goalpost that you are aiming for that would make you feel comfortable enough to align with the state on that?
Yeah. As I've said before, we're looking for a decrease in the mortality rate and a decrease in the sort of ability of this virus to spread so easily. So when we get to places where the mortality rate has in fact dropped, I think, there's consensus all across the country. Mortality rate is still super high from COVID, and we still all want to work hard to get it down. But I think at the point that mortality rate drops significantly and, it's less infectious than it is at the moment. I mean, this is, we're seeing the most infectious variants we've ever seen. We'd feel more comfortable in really thinking about this more like a common cold. But it's not a common cold right now, so we're going to stay the course.
But do you have a number in mind? Because I know before you didn't.
Yeah.
have a number.
We don't-
And it's good that we went
Yeah.
from 11 to 14 daily, but now down to
Yeah.
10.
Yeah.
So there is progress, but and again, I do understand that any death is.
Yeah, it's super hard.
Too much. But in terms of just being able to tell the public,
Yeah.
this is what we need to get to.
Yeah.
Because we know COVID is here to stay.
Yeah. I think we look at this and look at sort of what we experience for death rates from other respiratory viruses, and everyone knows the COVID is still much higher than flu, so we can just use flu as an example. I think for us, what we're really trying to do is prevent unnecessary deaths. So we'll keep monitoring closely. We keep talking with others. I've always noted that what we did here is we took the strong recommendations from CDC and from the state and used the health officer authority to make sure that on those very strong recommendations, we were actually asking everyone to go ahead and follow it.
My last follow-up on that is just as the public health director, I mean, would it not make yourself even feel better or the department feel better just to say this is our goal and to pinpoint it? Because I think without having it, I think that
Yeah.
it's just this unbridled authority that you have in terms of when will you allow
Yeah.
the state?
I think it's a fair question. I think in general, we've been a health department that has tried to put benchmarks on everything. I mean, remember, before the state even went from moving from a strong recommendation to individual preference on when people should wear their masks, we had already issued a framework that said when we get to this amount of transmission, we'll feel much more comfortable transferring. So I think the reason we haven't settled on a number yet is the team is still really looking at all of the different ways to assess when the risk of severe illness and death is too great for us to bear, and that in fact, in this case, the inconvenience of wearing that mask seems like a relatively appropriate step for us to ask people to take so that we can protect other people from having a very bad consequence.
I'll go to Ron Lynn at LA Times, and then I'm going to ask a question from Jackie Fortier from KPCC. One on monkeypox, two on COVID. Dr. Singhal, can you talk more about why you think monkeypox cases have dropped so much and how you expect things will go in the coming months? And then two COVID questions. Dr. Ferrer, why are you so concerned about BA.2.75.2 and are new subvariants like BA.4.6 and BF.7 making up a larger share of total cases simply because so many people have protection against BA.5?
Yeah, thanks, Ron. Appreciate both the questions. It's been a little bit difficult to actually assess how much protection being infected with BA.5 is giving you from a sublineage. So let's talk about BF.7. I'm not really sure yet. I don't think there's evidence yet that really explains thoroughly to us whether or not people are going to get reinfected who were already infected with BA.5 with a sublineage. In fact, there have been some tests in labs, mostly labs, that have shown that there can be reinfections. So I want to just note that there can be reinfections. And we certainly have had examples of people saying, I got BA.5, I got sick 3 weeks ago, and seemed to have fully recovered, and now I've tested positive again, 3 or 4 weeks later. Was it BA.5 the first time and it's BA.5 now, or were they one of the rare people here in LA County who had something slightly different? So I want to say we don't exactly know. What we do know is that people are capable of being reinfected, so that it makes sense for people to know that and adjust what they're doing, knowing that just because you got infected with BA.5 doesn't mean you're going to be protected against BF.7. And certainly doesn't mean you're going to be protected against BA.4.6. There is a greater likelihood, if you were more recently infected, that you've got some natural immunity that ought to protect you. But nothing is 100%, not natural immunity, not our vaccines. So taking steps to be careful and cautious about trying to avoid getting infected still is a sensible step to go. And I'm worried about, BA.2.75.2 the same way we're worried about, the proliferation of any new mutations that come along. Because what you're seeing when you see a picture of those mutations, it's highly mutated, looks very different, and therefore is capable of evading some of the protections we've put in place, both with vaccines and natural immunity. At this point, it's a theoretical worry in the sense that we have seen other subvariants and sublineages that show those same properties or similar properties that haven't, in fact, crowded out whatever else was circulating at the time. So I think every time we see a sublineage or a subvariant or a new strain that in some other part of the country or another part of the world is taking hold, we need to be cautious here and follow what we're seeing in our own specimens sequencing to better understand the possibility of that new strain dominating what's going to be circulating here, because obviously a new strain creates more risk for all of us.
And Dr. Singhal?
Oh, yeah.
Did you want me to repeat the question?
No, I think I got it. Yes, so thank you for that question. So I think when we're looking at the cases dropping and just our nice curve that we have been going over every week, I think the timing of when we started seeing that decline, we know that definitely vaccination is a very important piece of this, but you're also seeing how many folks we've vaccinated, and you could see that it's not just vaccination alone and that there's other factors that are also contributing to that decline. So one of the things that I mentioned today was also the immunity that comes with having the infection. So that is something that CDC is now mentioning as well, that when you have, as that immunity builds in certain networks, there's going to be a decreased risk of transmission. You're not going to have as many people that the virus can then go to. We also know inherently with this virus, it's very different than other viruses in COVID, and in that it's not easily transmitted. And so you do have to have close contact. There's more information coming out on this. There's going to be a science brief that's going to be released by CDC next week, which is going to talk about modes of transmission and what they've learned so far in the current outbreak. And so that will point to the fact that you really have to have the close contact with the lesions for the most part as the primary mode of transmission that they've seen in this current outbreak. And so that then also limits how much transmission is going to happen with this particular virus. There's also strong evidence that the CDC put out that there was behavior change, that folks did change their behavior that then led to decreased risk. And so I think all of those factors together have contributed to the declines that we're seeing. I think where are we going with this? So I think one important thing to remember is that this is a global outbreak. So, LA is a global hub. And so even if we were to get local transmission down, there will likely still be effects of cases coming in from externally as well. So there's always going to be that risk for, I think, at least a few months, if not longer. And so I think we are in it for the longer haul. We do want to make sure that we're continuing to talk about vaccination with our residents here, making sure that those that are at risk are getting vaccinated, knowing that this is likely going to be here for a few more months, if not longer. But it is very, very good to see that, if it is here, we're hoping that it's going to be a very low number of cases and will not begin to rise again.
Another monkeypox question from Jackie Fortier at KPCC. Dr. Singhal said half of the Genius doses have been administered. Has interest in the vaccine dropped with new cases? Why is it so low?
Yes. So first off, I do want to mention that we in LA County have been maximizing requesting whatever vaccine doses have been allocated to us. So we wanted to make sure that with phase 4 allocations from CDC coming to a close, we did want to make sure that we requested all of our doses that we were eligible to receive. And so we do have a large amount of doses right now, which is good. So we have them. We can now work on a slightly different strategy, which is going to be a longer term strategy of getting those doses out. But yes, we have seen that the number of doses being administered on a weekly basis has decreased. And as I mentioned, that's mostly that most of that decrease is being seen in our public vaccination sites. I think at this point, the work is really going to be with our community providers who are really going to be working with their patients one-on-one who are at risk and, identifying them, talking to them about their risk and saying that, hey, you need to get this vaccine. Let me give it to you right now while you're here. And that is what we're hoping to now kind of switch gears on and making sure that we're supporting our providers and that they are going to continue they've had a very steady march forwards in making sure that vaccine is getting out. And we're hoping that that's going to continue.
Any final questions?
I have a fentanyl question, if I could.
Yes, go ahead.
Noting that you're having a town hall next week. My question is, I just interviewed, in fact, DEA Special Agent Bill Bodner, LA-based. I'm sure you work with him. He calls this, the fentanyl crisis, the biggest threat to public health in terms of the drug out there in the U.S. right now. Noting that you are having that town hall next week, what is the role of public health? What are you doing right now to help combat this crisis? Because it is very much a crisis.
Yeah, I appreciate that. And I want to, also thank Dr. Tsai and our team here who have been working around issues related to fentanyl and other drug overdoses for years now. But fentanyl is a game changer because it's super dangerous and it's getting really added into all kinds of other drugs that are then sold illicitly and without people understanding what's inside of the drugs that they're consuming. So it essentially, it's really about poisoning now at this point because people are ingesting something that they're not intending or wanting to ingest, which makes the work really, really difficult. I want to go back to, one of the roles that we've always played is really acknowledging that we have to do a better job preventing people from becoming addicted and preventing people, particularly young people, from experimenting with dangerous drugs. And that part of that is our work that we're already and have been doing for the last few years in schools, where we've set up student well-being centers, where we really educate peer leaders, because I want to highlight how important it is for young people to have a voice in this and be well educated so that they can talk to each other. So we have peer leadership programs that are about, a whole bunch of issues related to student well-being, not just, really trying to be extraordinarily cautious about using illicit drugs. But it's really about student well-being, feeling good about yourself, feeling respected, understanding your emotions and how to manage them and how to manage your relationships with others, which again are issues that we think contribute to depression and anxiety among young people, which can in fact then lead young people to be self-medicating, which is some of what you're certainly seeing, or thrill-seeking, which is some of the other reasons why we may have many young people trying drugs that are inherently dangerous. I will say our work has been long-standing, but on this effort, we've been really trying to coordinate a lot with the schools. A few weeks earlier, we sent out alerts to the schools with offers on us being able to help them make sure that they had Narcan and connected all those school districts to Narcan so that every school district, not just LAUSD, has access to a life-saving drug that can reverse the effects of an opioid poisoning or overdose. We're also obviously offering a lot of educational materials. And as I said, we believe very strongly in a peer-to-peer model here, and opportunities to actually work with young people. We're also working really hard with the emergency rooms and with physicians. And one thing we know is when people get discharged after an overdose, they should be discharged with fentanyl. They should be discharged with Narcan. There are places where we can really make a difference. So people who have had one overdose are very likely to have another overdose. So let's get in front of that. Let's also start offering medically assisted treatments to people who are coming in to the emergency room with an emergency related to opioid use or drug use, and try to really start moving people into treatment and recovery. So I would say, we hope to cover a lot of that at the town hall, answer people's questions, make sure people know how easy it is to connect to services and support. But also, this is another effort where we're going to all have to work together. We all will benefit from making sure that people who are struggling with substance use disorders are able to find respectful treatment and places to go to get help and support. And that's part of what the work has to be. We can't just focus on sort of the poisoning related to fentanyl. We have to focus on the larger issue, build out a system that's able to actually address factors that contribute to substance use disorders, as well as people's opportunities to get into treatment and recovery.
The Special Agent Bonner was saying just awareness, raising awareness
Yeah.
is
Yeah.
really key. And
Yeah,
using
it
social
is.
media influencers to help
Yeah,
with that.
and we have to also understand that teens talk to other teens, so we're kind of missing the boat if we think that they're going to listen to me. I was a high school principal for a while, so I know that this is true. You have to make sure you're paying attention to developing teen leadership, youth leadership, and you have to understand that part of respecting young people is making sure they have good information that they can share with others, as well as good access to services and support. I think that's what we need to do as a county.
Vision Latina, the next question.
Sí.
I
Para
apologize.
nuestra audiencia hispana, mi nombre es Evelyn Rivera, vicepresidenta, si lo puede dar en español, por favor, para nuestra audiencia, que la vacuna viruela del mono, qué tan efectiva es, el 100%, que se nos puede dar un pequeño recuento en español para nuestra audiencia. Ana, por favor.
No sé, de veramente me tengo que ir, ya son las 3, pero lo hago rápido.